compulsive disorder. So, as I said earlier, and so first, kind of the purpose is we're going to do a little bit of the diagnostic criteria and talk a little bit about kind of what is the gold standard and kind of how we ask about and understand OCD and then how we can talk about it. And I have no disclosures to make. So really how the DSM-5 really looks at OCD diagnostic criteria is you have to have obsessions, compulsions, or both at the same time. And so we really need to understand first, what does that actually mean? So obsessions are really these recurrent, really persistent thoughts, images, or urges that are really intrusive and the person really doesn't want them to be there. And actually, most of us have like kind of these weird, random, intrusive thoughts that kind of get to us. But a lot of the times, for most of us, we might kind of look at that thought and go, oh, that's weird, or and kind of let it fly by. Whereas for a person who has OCD, when these intrusive thoughts come in, it's actually really distressful and it causes a lot of anxiety, which is really what's at the core of OCD. And the other piece of having that obsession is that it keeps coming back and it keeps coming back. And what the person tries to do, since they aren't able to let it go, is they're going to try to either suppress it or try to neutralize it. And either they'll do that either through having a new thought or an image with something else. And it's an action typically. And that's really where we're going to see kind of those compulsions kind of come in. And compulsions are really just repetitive behaviors that a person feels that they have to perform. And usually it's in response to that obsession or that intrusive thought or image or urge that came in. And usually it has to be done a specific way. And it's almost a little bit perfectionistic because it's a very rigid way of how it has to be done. And this can be done all sorts of ways. It can be often mental acts. So sometimes you don't even really see the person's compulsion because it might be something that they might be telling themselves. Maybe it might be something like a prayer or an affirmation or something that they have to tell themselves over and over again. And what it really does is it serves to kind of reduce that anxiety or to, again, try and neutralize either that thought, that image, that urge that just kind of came up. Or in some other cases, they might feel it prevents a situation that they're dreading. So, an example might be, for example, a person might have to cross the door several times because they think if I don't cross the door just right, it means I might have a bad day. And so, and usually what's really important is with these behaviors or these compulsions is that it's not necessarily realistic or really connected to the event that it's supposed to prevent. So, for example, my example with crossing the door, how you cross the door is not necessarily going to dictate the type of day that you're going to have. But sometimes, especially now that we're seeing kind of in these times of COVID, a lot of us are kind of washing our hands and keeping things clean more. And so I think that's where we might kind of go, oh, but is it OCD? Because we are trying to prevent a negative event. And there's a little bit of that fear, I think, collectively of what's going to happen, especially as far as COVID. But the other piece that we also want to think about is not only is it realistic, because in our case, hand washing is pretty realistic, but is it also excessive in what you might need to do? Because for a lot of us, what we've been taught in a health setting is, okay, we got to wash our hands with soap and we want to have it about 20 seconds and then we wash and then we dry off. And usually that's acceptable. But if we're starting to now see hand washing to the point where maybe it's 7 times, or it's to the point where maybe we're starting to have skin issues because of the rate of hand washing, that's where we might cross then and say, this could be OCD because now this is excessive in what we're trying to counteract. And really for the person, these obsessions and compulsions really take up a lot of their day. So especially in the way that we're looking at it to diagnose it, it really needs to be taking about an hour. And it really either has to be causing the person distress or it's getting in the way of the things that they want to do, either socially, maybe at their job or as a student, or any other areas of their lives that are important to them. And as always, and you'll see this with a lot of the diagnostic criteria for a lot of mental health issues, is that the symptoms that we're really looking at, in this case, the obsessions and the compulsions that are not caused by another medical condition or a different mental disorder or substance and medication use. So those are really the things that we're thinking about when we are trying to assess and diagnose for OCD. And we can go to the next slide, please. And one of the things that's really important, especially when we're looking at a person's prognosis, is the OCD specifiers. Because that's going to tell us, one, how a person may be likely to do in therapy and how long that course is going to be. So some of the specifiers are with good or fair insight. So this is where the person is having their sessions and their compulsions, but they're able to recognize that my beliefs or these intrusive thoughts that I'm having and the compulsions that go with them are probably not likely true. And these kinds of folks usually tend to have the best prognosis and outcomes because they're able to already kind of see that I know that I crossed the door several times because I think I'm going to have a bad day. I know it's not true, but I still do it because, again, that's part of the disorder. So being able to have that insight. With poor insight, this is where a person really believes that it probably could be true. But with this, you also want to be mindful of, because especially with younger kids, especially when you're thinking about their developmental level, it could be very likely that someone who is 6 or 8 might believe these things are true. And so that's something we always want to provide education, and we want to kind of tiptoe closely with younger patients. But with adults, it's a little bit more clear where we can be like, do they really believe it? And if they do think it's probably true, a little bit less, but we could still work with them. One of the big ones is with absent insight or delusional belief. So this is a person that is absolutely convinced that their OCD beliefs are true. This is probably the rarest type. It only happens in about 4% or less of patients. But obviously, these tend to have the worst prognosis. And also, you may be likely to see this specific specifier if the OCD symptoms are also happening within the context of another disorder. So, for example, if someone who's having, for example, something like schizophrenia, where you can sometimes see OCD symptoms when someone's in the middle of a psychosis, that's where you might see that absent insight and delusional beliefs. So sometimes we have to tease that apart as well. And the other big one is actually tic related. Just because, interestingly enough, and depending on the research paper that you read, it can be up to 30% of OCD patients have actually had either currently or in the past have had a tic disorder. Usually, we're going to see this the most in males that have had their onset of OCD in childhood. And we'll get a little bit later and to kind of tease apart, because the interesting thing is with tics, especially for complex tics, it can actually look a little bit like some of the compulsions related to OCD. And so for us, when we're making those diagnoses, it's going to be really important for us to really tease that apart and really start to see, is it really tic related? Is it really OCD? So that way the person can kind of get led to their best treatment. Next slide, please. So one of the really important things with OCD is that really what's at the core of it is, one, the anxiety that we kind of talked about before, but it's also having almost a dysfunctional belief system. And really what's part of those dysfunctional beliefs is kind of, one, an inflated sense of responsibility. So it's kind of that belief of it is up to me, for example, to make sure that I check all the doors 30 times so that nothing bad happens to my family. But again, we're placing that responsibility on ourselves. The other thing is placing excess importance on the thoughts that they're having. So you might see this a little bit in scrupulosity or like a religious based OCD, where you can kind of see in these patients where for them, the thought is already the sin. So by me having this thought, I'm already committing blasphemy. So again, we're putting excess important on the thought. One is the overestimation of danger. And this is something that is really classic, not just in OCD, but with a lot of anxiety disorders, where we're overestimating how likely something bad is going to happen. So one example that I love to use is airplane crashes. I think a lot of people get really nervous about airplane crashes, but if we really look at the statistics, you're actually in more danger in your car if we're thinking about how often this happens. But of course, a plane crash always makes the news. But part of that is because they're so rare, but it's something that for us, a lot of us, it pops up. And really, again, and this is also something that really goes with just anxiety disorders in general, there's a really big intolerance of uncertainty. And this is kind of with the OCD, it kind of manifests as that person's way of trying to do whatever they can to control an outcome as best they can. And so I wanted to talk a little bit about maybe some common themes that we might see in OCD, especially for this slide, it's really around the obsessions. So one, it's kind of having these forbidden or really taboo thoughts. And kind of what comes under that is one, which is probably the most popular one, is aggression. People with OCD often have fears of that I might steal from someone, I might commit a violent act, or I might hurt someone, or there was a case a long time ago when I was in grad school where it was a woman who was afraid every time she hit a speed bump because she thought that she hit somebody and that she must have run them over. The interesting thing is people have these fears, but they're actually probably the least likely in the world to actually do any of these things. But the thought pops in their head, it's scary, and they really worry about it and they try to do everything they can to prevent it. And that's probably one of the most popular ones, especially that you're going to see in adults. The other part is thoughts that are of a sexual nature. So these might be things where maybe a person is not necessarily questioning gender identity, but really in a way that is unrealistic and doesn't actually go with their identity. Or it may be themes of like incest or pedophilia. But again, they're not likely to do it, they're not acting on it. It's not even a thought that is pleasurable. It's usually a thought, again, that causes distress, causes anxiety. Why did this even pop up? So that's really important. And then scrupulosity, which is really thoughts that have a religious undertone to them. So one of the important things with scrupulosity is that it's really important to have a good understanding of what the person's religious beliefs are and what is actually acceptable within the person's culture and their religion, because that's what's going to help you identify, again, if it's crossing that line of being excessive. And then harm to self or others, especially with younger patients, especially with adolescents and children, you're really going to see again that harm coming, and that really tends to predominate the themes of obsession. So one is the other most popular one, which is contamination. Again, fear of germs, fear of getting dirty, fear of things that are sticky. And then pathological doubt. So this is really where we see kind of our excessive checkers. So these are people that need to keep going back to see if the stove is off. This is, and again, we all had those thoughts of, oh my goodness, did I leave the curling iron on? We've all had those thoughts. But this again goes to that excess where, like, yes, we've already checked it once, but now we need to go back 30 times. So somatic and bodily sensations. So this is going to be, again, like Oh, I felt a twinge. Does this mean that I'm now having appendicitis? Does this mean? So again, that excess. Again, with checking or with bodily sensations, again, anything unpleasant we're trying to avoid. We also see kind of the hoarding, saving thoughts, and we'll talk about kind of those differences between OCD and hoarding disorder. Some of that you're going to see also around symmetry and exactness. So this is where you kind of see things like counting or arranging things in just the right way. And then a little bit of that magical thinking. So again, if I don't arrange my books in just the right way, maybe this means that I'm going to have a car accident this afternoon. So again, a little unrelated, but we really have that power belief. And then we can go to the next slide. So common compulsions, cleaning and washing, which is probably the most well-known and probably what people mostly associate when they think of OCD. Repetition of any rituals. You might see this, for example, with prayer or with arranging things, checking, counting, ordering and rearranging things, collecting and saving items. You'll also see this as far as like someone needing to tell or ask or confess. You might also see this in needing to touch or tap or blinking or staring or saying things. A lot of people actually tend to have mental rituals. And those are kind of the toughest to kind of tease apart. So it's really important to ask, like, hey, is there anything that you're saying to yourself? Is there anything that you're doing? Are you counting something in your head? Because that's not always as obvious as some of these other ones. You will also sometimes see ritualized eating, and that's going to be important to ask about because, again, you will also see that in eating disorders as well. But the big one I would say is avoidance. So often the person is trying to avoid either something that'll cause the thought, things that can get in the way. So an example would be if someone had, for example, an aggression obsession of I might hurt someone, they might try and remove all the knives from the house. So that would be an example of avoidance. And the really important thing with compulsions is that for the person, it's really accompanied by a sense of physical discomfort and a sense of incompleteness if they don't do it, and if they don't do it just right. And that's really a big key factor with this. And what you'll also sometimes see with OCD patients is you'll see kind of also those physiological symptoms of anxiety. So those can be things like panic attacks, stomach aches, feelings of dizziness, hyperventilation. So you can also see that again, if those compulsions are not done to that exact standard. Next slide, please. So I thought it would be most useful to kind of talk about some common things that can crisscross with OCD and talk a little bit about how can we differentiate and what kind of questions maybe we can ask in order to help us really tease apart OCD. So one of the big ones is body dysmorphic disorder. And this is kind of where a person is not necessarily seeing themselves accurately. And so what you really want to ask is really, what is the theme around the obsessions and compulsions? Because what's going to separate that from OCD is that we do have some obsessions and compulsions in body dysmorphic disorder, but they're only limited to the person's physical appearance. So are you also worried about your family in doing these things? Or is this seriously only because we don't like our nose or our hips? And so that's going to be really important to ask. Trichotillomania is also within the OCD family of disorders in the DSM-5, and so is excoriation or skin picking. And so again, sometimes obsessions are not present with these disorders. So a lot of times with trichotillomania or excoriation, the person will talk about like, sometimes I pluck or skin pick, and I don't even think about it. I'm not even aware that I just did it. And so with that, we really then are seeing that really the only compulsion they have is either the hair pulling or the skin picking. And so that's going to be, again, a way to kind of differentiate that. So with hoarding disorder, which is also in the OCD section of the DSM, they have persistent difficulties with discarding. And it's really important to start asking, why is it hard for you to get rid of your stuff? And so an example will be if a person just, oh, I just don't like it, I just want to keep my stuff. That may be more hoarding, but if they're saying, hey, I don't want to get rid of the newspaper because what if I get rid of information that is going to prevent something bad from happening tomorrow? If they're going to kind of those kind of thoughts as to why it's difficult to get rid of things, then we're probably more along the lines of OCD rather than hoarding disorder. And again, with eating disorders, it's important because often they're comorbid with some kind of anxiety disorder, and you can have both. Actually, with eating disorders, you can have OCD and in eating disorders, but with eating disorders, the obsessions and compulsions are usually only around food. And you really want to start asking the reasons why is it because with eating disorder, it's really around weight loss or body image or body shape. Whereas with OCD, you might see things like, oh, I don't want my food to touch because maybe there's a fear of contamination. And there's going to be germs from one to the other. With generalized anxiety disorder, often the worries that a person has are really related to more real life concerns. How am I doing at school? Is my boss going to be mean to me at my job? And again, it's not always accompanied by a compulsion. So again, we really want to know, what is the source of your anxiety? With phobias, the anxiety or the distress that the person is really limited to either the situation or the fear object. And usually you don't really see a ritual. You'll see some avoidance. If you're afraid of public speaking, you're probably going to avoid any opportunity where you have to go up in front of a group. But it doesn't mean that you're necessarily going to do a ritual about it or necessarily say things. So with tics, which I kind of alluded to earlier, with complex tics, it can look like a compulsion. And so it's really important to really start asking questions about the origins of that person's movement. Because obviously with tics, these are involuntary movements, but often with tics, you have what's called the premonitory urge. So the premonitory urge is a physiological sensation. It's not necessarily anxiety driven, but it's a physiological sensation that kind of indicates to the person that a tic is coming. And so I worked with someone with tics who was talking about like, well, before she has to lean her head back, she starts feeling kind of a sensation coming from her shoulder blades and going up the back of her neck to go back. That's not necessarily an obsession. Whereas with the OCD, what is the thought that's happening before the movement? Oh, well, I need to do this because I'm trying to prevent this happening, or I'm trying to make sure that like my prayer is just right so that God is okay with me. And that's going to be very different from where a tic is coming from, but that's where it can get confusing because for both compulsions and for tics, there still is that physiological discomfort that is happening. And obsessive compulsive personality disorder. So this is often what actually people are really talking about when they say, oh, it's my OCD, when they really want their workplace or their stuff to be neat and orderly or for things to be clean. And the thing about OCPD is that it's really a pattern of perfectionism, orderliness, a lot of rigidity and stubbornness. And this is really what's often you see depicted in the media, or even as our friends say, oh, it's my OCD. But the thing about it is that it's egosyntonic. This is something that a person identifies as being part of who they are. And it's not causing them any distress. They love having their closet color coded, and it's fine. Whereas with someone really with OCD, this is all very distressful, and they don't want to be this way. Next slide. So we also want to talk a little bit about some common assessment measures that are used either in research or with psychology. So we have them. So really, diagnostic interview schedules are mostly used in research because they're pretty long and pretty extensive. So for example, the SCID, that one can go on for for hours, but if necessary, some psychologists, what they'll do is they might take kind of the OCD section of the SCID and administer that. But the most well-known is probably the Yale-Brown Obsessive Compulsive Scale. So this one is used a lot in testing, and it can be really useful just to see like what the symptoms are. And it is very extensive when it'll ask about specific things in probably every category. And the other thing that is really important is you might want to assess insight, and this can be done either through clinical interview. There's also things like, again, Brown Assessment of Belief Scale or the Overvalued Idea Scale. So again, we're going back to that idea of putting that excess importance on thoughts. We also have Obsessive Belief Questionnaire, which again, because we're going for that dysfunctional beliefs, and the Family Accommodation Scale, which is really important because we also want to know how much are the people around our patients actually, accommodating or enabling them or letting them kind of work this thing out, which may not always be helpful. And it's important to know for therapy. Next slide, please. So I wanted to talk a little bit about treatment and how OCD is typically handled. So with medication use, really SSRIs have kind of been prescribed as kind of first line. But kind of the important thing to kind of remember is with adult, they're seeing kind of larger effect sizes necessarily than in youth. But again, as far as medication, that's really kind of the first line of treatment where people are going. With psychotherapy, really exposure and response prevention has actually been shown to have greater effects than just medication alone. And it's probably considered at this point, probably the gold standard for treating OCD. And exposure and response prevention is a form of CDT that is really focused on one, exposing the person to the source of their anxiety and preventing the response. So really preventing the compulsion or that attempt at neutralizing that anxiety. And so one of the interesting things is there was a study in Britain about youth that what they were calling treatment resistant OCD. So these were kids that had been in therapy for OCD, had not been helping, and they decided to kind of look at what was happening. Why was it treatment resistant? And so they had these kids actually work with OCD specialists. And what they actually found is that one, the treatment that they were getting was not necessarily adequate to treat the problem. And really the most common problem that they saw is that there was insufficient emphasis put on the exposure point, which is actually really important when you're treating OCD. And what Waller found is that, especially around children, therapists may actually avoid kind of that behavioral element, the exposure element of CBT with exposure prevent retention, because sometimes therapists have their own anxiety because the fact of the matter is you are going to trigger distress in patients. And that's really important to know about using exposure and response prevention. There will be distress. You are exposing them to the source of the anxiety, and that's okay as well. But we can't let our own anxiety of causing someone distress, prevent them from getting the treatment that they need. And next slide, please. And so let's talk about really how it's done. So with CBT, with exposure and response prevention, kind of the first piece is always, whether it's adults or children, you need to establish rapport with the patient, and you have to provide psychoeducation. Patients normally do better if they know, why are we doing this? Why are you going to make me not wash my hands after I touch Play-Doh? Why? And this is why. So it really is the therapist explaining kind of those mechanisms of anxiety, how anxiety is maintained by avoidance. This is why we're doing this. This is why we're going to prevent it. And we want to cause that habituation, which kind of the way I usually explain habituation to people is that it's basically that you've been exposed to something for so long that it doesn't cause a reaction anymore. And so usually the way I talk about it is, for example, if we take a shower, usually when you come out of the shower, you smell like your soap, you smell like your shampoo, right? But eventually you don't smell it anymore. But maybe if you go to hug someone, they might say, oh, you smell really nice. It doesn't mean that the smell ever went away. It just means that you've been exposed to it for so long that it doesn't register anymore. And that's really the goal of what exposure and response prevention therapy does. So once everyone is on board, usually you then collaborate with your patient and the family as well to create a fear hierarchy. So again, you're going to systematically go and start exposing bit by bit as the patient is ready. And really the important thing, and one of the things that goes for best outcomes, is the earlier exposure gets in, often you're going to have better outcomes in therapy. Also, you're usually going to teach the family and the individual, appropriate coping skills, and you're going to train the family and the individual as well to kind of, one, not rescue them. There is a temptation to rescue someone that we love when they're in distress. And also how to coach them and handle this, because with exposure and response prevention, it's not just work that you're doing in the session. There's a lot of practice that has to happen outside of the session as well. And you are going to be doing practice exposures throughout the week as well. The other thing you're going to also start with is beginning what's called interoceptive exposures. So these are exposures to the physiological sensations, especially if you have a patient that is dealing with physiological sensations of anxiety or panic attacks. You're going to expose them to those symptoms first so that they can kind of habituate to, okay, I can handle feeling dizzy, or I can handle it when it's a little bit harder for me to breathe or I start hyperventilating. Because chances are those symptoms are going to show up once you are also exposing them to the real thing. So then you may also start using imaginal exposure, and that can be used as a tool where you really are having the person imagine first that they are in the experience that they're trying to avoid. And it's a very useful tool, especially for patients who maybe have severe anxiety and maybe don't feel ready to go quite to an in vivo exposure. But one of the important things with these exposure is the person has to be exposed to their own anxiety. So the biggest thing is we want to avoid any safety behaviors that the patient is going to use. So obviously we can definitely prevent any physical behaviors. So those are going to be maybe like your tapping, your touching, kind of compulsions. But this is where we kind of go back to kind of those mental compulsions. So we really want to get into, are you saying anything to yourself? Are you trying to relax yourself? Are you trying to imagine yourself away from this situation? Because we don't want that either. And also we want to avoid any medications like benzodiazepines or alcohol or anything where it's going to try to take the edge off. We don't want that. We want them completely immersed in the experience. And that's usually where you start kind of beginning those in vivo exposures, and you're going to do them over and over and over again. And the other part, which is kind of the CBT work of it, is again kind of examining those thoughts, teaching your client again with classic good CBT as far as being able to evaluate those thoughts. Are those thoughts helping you right now? How realistic are they really, though? And being able to start also creating those challenges. And so for those of us that are not therapists, so something you can ask patients is kind of when they are telling you like, oh, yeah, I'm dealing with OCD, maybe I started seeing a therapist or whatever, you can start asking them, oh, what kinds of things are you working on? Have you guys started any exposures? How long have you been seeing them? Because one of the things you want to know is, one, are they actually doing the exposures? Because at least that'll be able to kind of let you know if they're not. And maybe they've been seeing this person for 6 months. Oh, we haven't started exposing. Then that'll also give you a sense of maybe that might not be the best approach, or what's kind of getting in the way of that. And really, when you guys are referring out, you always want to refer out, does this therapist familiar with exposure and response prevention? Those are really the keywords you want to use. And especially in the psychology world, we'll recognize that. And so that's really the referral. And that's always something you want to ask. Is this something that this person does to kind of help with OCD and anxiety? And next slide, please. So those are kind of a basic overview. And at this point, if anybody has any questions, please feel free. And thank you so much for having me.
Thank you so much, Stephanie. That was a wonderful presentation, and you did such a great job explaining all the different parts of it. So we truly appreciate your time, and it was just so wonderful. So thank you. Did anyone have any comments, questions, or thoughts for Stephanie? Feel free to unmute or chat in.
Hi, Stephanie. Thank you for that presentation. I have a real quick question about OCD and autism diagnoses and how I know a lot of people with ASD that sort of present in some of the repetitive behaviors and where that line is as far as that co-diagnosis.
Yeah, you can have both. You can have both. So with autism, so one of the things you really want to kind of separate out is, again, what is really the function of the repetitive behavior? Because sometimes you can have repetitive behaviors in autism that are just self-stimulating. They just feel good. They're great. I enjoy them, or, it makes me feel better. And that's really something we want to look at. And we also want to look at, again, with rigidity, because that also happens with autism, where there can be distress. I think kind of the most common stereotypes that we think of is the kid that's lining up the car. And if we take away like a car and mess it up, we're horrified. But again, we want to really be sure of what is that purpose? Is there an unrealistic thought going on behind it? Are we preventing something from happening? With autism, they're not really preventing necessarily anything. It's just, I just want my card lined up. Or it feels good to kind of do these self-stimulating, self-regulating behaviors. And again, and that serves a very different purpose, because with autism behaviors, it's a little bit more of that self-regulation piece. And that's, I think, what can also make it really difficult to tease apart from OCD. So that was a wonderful question.
Thank you. That was very helpful.
And Stephanie, I actually had a question too. I know you mentioned the inflated responsibility aspect of OCD, and let's say someone had to check if the oven was off or something. How would you guide like a family member or someone who's there witnessing that in that moment? How would you guide them to approach that situation? Like, is there a certain thing that you could do or say to reassure the person that you don't have to check it for the fifth time, it'll be okay? Or is that something that would make it worse?
That honestly, that's actually one of the hallmarks of OCD. And it'll probably let you know that maybe they need a little more help than we thought. Because if you're able to say, like, would it be okay if I check the oven? Hey, I just checked it if it's okay. If that person's going, no, it has to be me for you, then that may be maybe a conversation of having, like, listen, I've been noticing that, you've been really struggling with this. I'm noticing that you're having to check, is everything okay? What's going on? And maybe even start to really have that conversation of, how does this make you feel? Do you think that would you even be open to something like therapy or counseling? Because, part of it is like, we can lead people to therapy, but you can't make them go. And so maybe this will be the time to, for you, it's going to be more about being open, being gentle, being able to say, I'm seeing that you're struggling. Where are you at? Do you feel this is something you would even want to work on? Maybe they want to work on something else. You never know.
Right. Absolutely. Thank you so much.
I see something in the chat.
Yeah.
So I work in a clinic that has an 8-session limit before the patient either has to terminate or refer out. Any ideas for meaningful interventions within such a limited time frame? That's a great question. So kind of with that limited time frame, you can already start doing some great things. So kind of one of the first things you're going to want to do is psychoeducation. Really let them know, what is this about? What is it that they need to be looking for? What kind of therapist we want to refer them out to if we really do have that limit? This is why you should be continuing with this kind of therapy. And you can even already start with small exposures. So that can be thing of like, well, maybe we can start more with the interoceptive stuff. Well, okay. actually, I have to keep brushing my hair because, my hands tingle if I don't. Okay. Well, maybe we'll start some exposure, maybe like sitting on our hands a little bit until they tingle a little and start working on those interoceptive. And then you can kind of, let the next person know, like, hey, we've already started kind of these interoceptive exposures. You can get them lined up for an in vivo. So there's still things that you can do for them. And I think you guys have such an important job, especially if you're setting them up for the next person.
Thank you so much, Stephanie. And I'm glad, Rachel, that answered your question. Were there any other thoughts, questions, comments, or maybe personal experiences in your clinics or your experiences that you've had? Feel free to share with the group.
Thank you so much for that. I just wanted to say you did a really wonderful job. Would something like being a hypochondriac, is that like me? It's for a friend, okay? No, I've had experience with OCD when I was younger, actually. But would being a hypochondriac be like somewhat of a version of OCD, I guess?
It's definitely anxiety, but I would put that more towards like a somatic or even an illness anxiety disorder. Because again, it's not just unrealistic, but it's necessarily, I'm actually really worried and specific about these specific areas or about becoming ill or about the functioning of my body. Because again, we also want to check, is there a ritual that goes with this person? And again, is it in excess? If you're getting lesions because you're washing your hands so much because you're afraid of getting sick, probably might be OCD.
Yeah, this is so hard
again,
because there's so many crossovers with things. So yeah, I think you explained that well.
And that's really the hard part, honestly, not just with OCD,
Yeah,
but with a lot of anxiety disorders. So really always when you're asking about these things, it doesn't matter what kind of clinic you're in, you always want to ask, like, what is it that we're really afraid of here? Because that's really what's going to help you kind of making that diagnosis and knowing where to refer out.
That's a great point, Elizabeth. Lots of crossover, and you did such a great job, Stephanie, with differentiating it and showing the similarities. So that was really interesting.
And that's the really hard part. A lot of things in mental health tend to cross over. Absolutely. And I think that's what gets really tough. And I'll even have patients that are convinced, like, no, this is my diagnosis. Like, I read it online. Dr. Google said. And then, like, once we start really talking about things, I end up going, you know what? Actually, based on what you said, this is what I'm thinking. I can see why you think this, but let's talk about it together. Do you think these things apply? And we end up having a very different conversation.
Yeah, and I think sometimes I think people are afraid too of like a diagnosis, or might be, like pushing back on that too, because sometimes it's hard to see or fight it and say, this person's only met me like one time. How could they possibly know? I think sometimes people have a harder time to sometimes recognize that. And with the dosing, when you were speaking about adults and children, do you mean that they
they were looking at effect sizes, so statistically speaking, of just how effective an SSRI was. And so what they were noticing is that on adults, it does have large effect sizes. So clinically, when we're thinking about that, like, oh, this is actually going to be really helpful. But when they were looking at youth, it was actually more medium, smallish effect sizes. And that can be for a whole host of reasons. I'm not a psychiatrist, so I really can't necessarily explain like what's happening with neurological functioning and pharmaceutics. I will leave to my colleagues. But it was just very interesting to kind of see the differences in effect sizes and how, we're going to think about that when we're disseminating and working in our clinics and how we think about these things.
I also wanted to say it was really interesting to see. I know a lot of, like you said, a lot of people can loosely throw out the term, oh, I have OCD, but then that's the differentiation with the OCPD versus OCD, which is really interesting.
I think it's just because we see it a lot in popular culture. I think it started like back in the, I'm going to probably get the years wrong, but I think like the 60s or 70s with like, what is it, The Odd Couple? Where like you had the one guy who was like a neat freak and the other guy who's like a slob. And that's kind of their first taste. And then the interesting thing is I was seeing like a lot of OCD gets played in popular culture like Monk or Big Bang, where the compulsions are like funny or it's like comedic relief. But when you actually meet these people and get to know what their lives are like it's actually really not funny. And it's actually really distressing
Right.
for them. And especially, it's a lot to think about because also like organizations become really popular. I mean, look at Marie Kondo, the Home Edit, whatever hot new organization thing is going to come that I'm going to watch on Netflix. and how many times do those people say, oh, it's my OCD? And I'm just like, no, you're living and you're loving your neatness. And I am too. I've lived for the Instagram pictures of it. But again, that's very different from the lived experience of somebody with OCD.
Absolutely. Yeah. And so would you say OCPD is more common than compared to OCD?
I wouldn't say it's necessarily common because one, neatness is just a factor of it. So with personality disorders, it's really a pervasive way of kind of interacting and going throughout the world. You really don't really diagnose these until adulthood typically. And it has to be a really established pattern. And honestly, the reason it becomes a personality disorder is that because it's starting to get in the way of your relationships. It gets in the way of, that rigidity, that perfectionism, that orderliness. It starts to get in the way of your ability to socialize or do things or do your job. And so that's where it starts to become problematic. And that's always something we always want to keep in mind. It's okay to be neat and orderly. It's okay. I have my books arranged in rainbow order. It's okay to want a tidy workspace. That's totally fine. But if it starts to get to the point where it's causing you distress or it's getting in the way of you being able to live a life that you like, that's where we're going to say this could be problematic. This is maybe that point where we want to see someone. So I also don't want this presentation to be like, it's bad to be neat and orderly. No, you can still like those things. But again, we want to make sure that it's still within the context of you being able to live a life that you like and to have healthy relationships.
Absolutely. Thank you so much.
Of course.
Were there any other comments or questions from the group? I know we still have about 6 more minutes, but I didn't want to end the session early if we didn't have to. Alrighty. Well, thank you again so much, Stephanie. This was such a great presentation, and we really appreciate your time. And you did such a wonderful job explaining and presenting, answering questions. So we really appreciate you.
Thank you guys. This was such a pleasure. So thank you again for having me.
Absolutely. And again, we'll have this on YouTube as well. So a lot of the folks who couldn't attend live will probably watch it after the fact, which is always such a great platform to have that option too. The only announcement that I have is that our next session will be on August 4th, and Amanda Newhouse is going to be discussing managing sexualized behaviors. So keep an eye out for that reminder, and we'll see you all next time. Thank you all so much. Thank you, Stephanie.
Thank you.
Thank you. Bye, everyone.
Bye.
Thank you.